Hello everybody, and welcome back. This is Peter Pronovost, and today we're going to talk about learning from defects. I hope you'll remember that learning from defects is the critical part of the CUSP program, the Comprehensive Unit-Based Safety Program, that allows us to move beyond these events that we don't want to be happening from recurring to making a system where we reduce the risk of harm for future patients. Our learning objectives today are one, to help us understand the difference between first order, or what might be called recovery, problem solving, and second order problem solving, which we're going to call learning. Secondly, to understand how to address each of the key questions that define learning from mistakes. And they are: what happened, why, what will you do to reduce risk, and how will you know that you actually succeeded? These are not easy, but they'll make dramatic improvements in the safety of your patients. Now, the typical approach to improving or learning from mistakes is exemplified by this Clint Eastwood picture. It's a shame and blame. You're wrong, we expect perfection, and if you don't, you're annihilated. We know that that's not very effective because it doesn't tease out the systems that underlie the causes of this. And as you remember from our science of safety, every system is perfectly designed to achieve the results that it gets. So what is first order and second order problem solving? Well, these are terms that come from our colleague at the Harvard Business School, Anita Tucker. And first order problem solving is simply recovery. That is, the patient didn't get something, and so you go do it. It doesn't do anything to reduce the harm for future patients. And we do this 10s or 20s or 100 times a day in healthcare, right? The supplies aren't there, so the nurse runs down the hall to get them from another unit. And that helps the patient, and we need to do that. But we need to couple that with what we'll call second order problem solving. That is, reducing the risk that future patients will suffer the same harm. So rather than just going to get the supply, you then take the time out to say, why wasn't it stocked, and what are we going to do to make sure that it is? Second order problem solving is really where the value from improving safety is going to come from. Now, learning from defects is second order problem solving. Indeed, we're going to define learning as if we do second order problem solving. That is, we reduce the risk that it happens again. So let's define first, what do we mean by a defect? Well, there's a lot of pushback amongst clinicians about, do we make defects and what do we do? I'm going to propose to you a very simple and pragmatic definition, much like most of our work is. And that is, let's not get bogged down. Let's call a defect anything either clinical or operational that you don't want to have happen again. We'll call it a defect. Could result in patient harm, could result in dissatisfaction for you. There's a lot of defects in healthcare. And there's multiple sources of them. They include adverse event reporting system, sentinel events, claims, infections, complications, and perhaps most powerfully, we call it our poor man's error reporting system, simply asking your staff, how is the next patient going to be harmed? As you'll remember, that's one of the early steps in the CUSP program, to really surface what these defects are. And I hope you have done that. If you haven't, it's a great time to go start it with your staff. Now, we'll define learning as being able to answer 4 questions. What happened? Why did it happen? What will you do to reduce the chance that it will occur? And finally, how will you know that you actually reduce the risk that it will happen again? That is, how do we know you actually did second order problem solving? Now, you may ask, well, why don't you just measure the rates of these things? That's how you're going to tell if you learned. And that's a great point. Typically, these events are rare. They have denominators that are often unknown. They may not be clearly defined. And it would be enormously resource intensive to measure these things as rates. And so typically we measure our degree of learning. Now, when you're trying to understand the event and describing what happened, what you want to do is put yourself in the place of those involved and construct the timeline of what happened very factually. You don't want to be a Monday morning quarterback and judging people. What you want to do is say, I am trying to understand why these decisions were made the way they were, not trying to explain them. Now, we know, though, that most of those decisions are guided by the systems, that is how work is organized. And Jim Reason is, the father of much of the safety effort, has this wonderful quote that says, rather than being the main instigators of an accident, operators tend to be the inheritors of system defects. Their part is that of adding the final garnish to a lethal brew that has long been in the cooking. And the second part is for us to understand these system or latent factors. So why did this event happen? They often result from production pressures, and hazard may not be visible until some triggering event occurs. Now, these system factors are complicated and they're nested within each other, and they range from characteristics of the patient, they may be sick or old, characteristics of the task, it may be ambiguous, characteristics of the provider, they may be fatigued or not skilled, characteristics of the team, they may not speak with each other very well, characteristics of the work environment, it may be noisy or loud or dark, characteristics of the department, that they may not put sufficient resources to staff the unit, characteristics of the hospital, of the way it's organized, and finally institutional or perhaps even societal factors. This model we've adopted from Charles Vincent works, and the idea is to help you develop lenses to see systems, to think through when an event happens, could this have been due to training? Could this have been due to teamwork? Could this have been due to my own skill or fatigue, so that we could tease out what happened? Let me share with you an example of a case that we try to tease out system factors that we published in the Annals of Internal Medicine. The case involved a patient who had a dialysis catheter that needed to be pulled. The patient was sitting in a chair. The doctor in training walked in to pull the catheter. The patient's nurse was in the room. The doctor said he was going to pull this catheter. The nurse kind of thought it was unusual that we don't usually pull these catheters when you're sitting in a chair. We usually lay the patient back in bed and put him in Trendelenburg. We do that, by the way, so the patient doesn't get an air embolism. But the nurse was uncomfortable speaking up because the last time she spoke up, she got her head bit off and was really shy about doing this now. She had met Clint Eastwood in the beginning. There also wasn't a clear protocol for how to do this, so she had nothing to refer to, nor did the doctor, about how exactly am I supposed to do this. And there weren't real clear rules about what the training and supervision were needed to do this procedure. Procedure was guided by the old see one, do one, teach one. That is an approach, see one, do one, teach one, that is perfectly designed to give some people air embolisms. And lo and behold, this catheter was pulled in the sitting position. The patient got an air embolism and they suffered harm. Now, the easy thing would be to say, oh, dumb nurse, why did you do this? Or dumb doctor, why did you do that? But that would be anemic. It would do nothing to do second order problem solving, because the richness is in fixing these systems. So how do we go about doing these? Well, in this model from Jim Reason, the holes in the Swiss cheese are these latent factors, these organizational vulnerabilities that we all live with every day. If I was more tech savvy, we would make them animated so they open and close and move because it's dynamic. And sometimes when all the barriers or the holes align and there's no barriers, harm could occur. But what they also mean, the hope side of the story, is that if we plug any one of those holes, we may be able to prevent harm from occurring. And that's what we have to start to doing now. So how do you decide what you're going to do? Well, importantly, you have to prioritize what are the most important contributing factors and interventions. What I've seen happen in healthcare organizations now is many of them have gotten lenses to see systems. And when they do their incident investigations or root cause analysis, they'll come up with 10, 20, 30 contributing factors and try to develop interventions for all of them. And that's in some ways naive. You don't have resources to do them, and they all don't contribute equally to the harm. Rather, what we like you to say is let's prioritize what are most important. But when you're designing interventions, remember from our science of safety these safe design principles. And they are standardized whenever you can, and if you could, eliminate steps so the defect doesn't occur, like our ATM machine. Create independent checks or checklists for things that are mission critical. And finally, make mistakes visible. Make sure you way to make them visible and learn from them. I hope you also remember that these principles don't just apply to technical work, but they apply to teamwork. So if teamwork was a problem, think of ways you can standardize it or create independent checks for your teamwork. Now, one practical way of prioritizing contributing factors, it's a way we borrowed from aviation, is simply to make a grid of where you list each factor, rate on a scale of 1 to 5 how important it was for the current event, with 5 being very high and 1 being low, and how important likely will be for future events. That is, again, 5 is very high, 1 is low. Remember, you can't fix all the factors, or if you could, you'll do them superficially. We're aiming to go an inch wide and a mile deep rather than a mile wide and an inch deep. Now you have your contributing factors organized, and your role is to say, well, what interventions am I going to do? So I would suggest that you brainstorm interventions that may target each of the contributing factors that you identified that are most critical to driving the problem. In a practical sense, we typically only pick the top 3 or 4 contributing factors because we know we're not going to have resources to put more than that for interventions in, but you can judge that for yourself. And then for each intervention, we also want to make sure, because you may have multiple interventions, that you focus on the ones that are most likely to make care safer, to do second order learning. So we'd ask you again to rate how well this particular intervention solves the problem or mitigates that contributing factor. And then what is critical, also rate, do you actually believe that you'll be able to implement and execute that intervention as intended? I can't tell you the number of times I've sat on investigation teams where one of the intervention would be, okay, let's get all the surgeons and the emergency room physicians and the nurses and the anesthesiologists to do team training. Great idea, but when you sat down and said, okay, guys, time out, is this really going to happen? Do you have the resources? Do you have the political will? Do you have the organizational infrastructure to pull this off? And if the answer is no, you either have to get those resources or take it off your intervention list, because this isn't just an exercise of checking a box for a regulatory agency. This is about making sure another Josie doesn't happen, and we have an obligation to do that. Typically, what we find practical is to say, let me pick the top 2 to 5 interventions and focus on them, and then develop an intervention plan. Now, what's an intervention plan mean? Well, frankly, we're asking you to do 3 things. Assign a person who's in charge of it, clarify what the task that they need to do, and give a follow-up date. So I might say, Chris, I would like to review the current protocols for this procedure or develop a draft protocol, and let's see that within the end of the week. That's typically noted, and we move forward. Now, when you're doing your interventions, remember the principles of safe design that we talked about: standardization, independent checks, and learning from mistakes. Here's a more detailed and more essentially blown up idea of those principles of standardization and learning and independent checks that are used in many industries. These happen to be from the Lean Sigma program, but you can think of what are forcing functions or constraints that could make this error less likely to happen. Is there any automation or computerization I can use? Could I make a protocol? Could I have checklists? Are there rules or policies? Is there some education? And the weakest is to tell people to be more vigilant. Now, I don't know about your organization, but I can tell you in mine and almost everyone I've seen, 90 to 95% of our interventions are re-educate or be more careful. And that's not likely to be very effective. Indeed, we were thinking about some common mistakes. So let's take connecting an epidural catheter to a patient's intravenous catheter. As you may know, that risks introducing local anesthetic, most often bupivacaine, which are quite often cardiotoxic, into a patient's bloodstream. It can kill them. And though that happens around the country, our typical response is be more careful. Try to be more vigilant. We may have an education program. Some of us have put stickers on the end of the epidural that says epidural only, so that may be a checklist or a rule to make it visible. But what would be much more powerful is to do a forcing function to redesign that equipment so that those two catheters, the epidural and the IV, don't fit together. But that's something that has to happen at a country level. Very few, if any, of our organizations have enough clout to get the system to change like that. But if you think of the money we spend collectively telling nurses and doctors to be more vigilant and be more careful, and the probability that those interventions are actually going to work, you may think we're the most inefficient industry in all of the planet. We have to start using as high and as strong as of an intervention we could. So stick with forcing function and automation and standardization whenever you could, and then checklist and rules. And lastly, only as a default, education and being more vigilant. Now, the last step, and it's often the most neglected and overlooked, is how do you know that you actually reduced risk? You see, because this work isn't just about thinking that we did good. It's about looking Sorrel King in the eye and knowing that you did reduced risk. And that's not easy for these rare events because remember, we can't measure them as rates. So what do? Well, we think of this measurement on 4 levels. And they go from the weakest but the lowest amount of resources needed to the most labor intensive but likely the most valid. And you have to decide how important this event is for your organization. Is it worth spending the resources? But the weakest is, did you create a policy or a procedure? As you know, there's often miles between writing a policy and its use, so that particular one doesn't give me much comfort. The second is, do staff know about whatever we did? That is, do some educational assessment. If this is our new policy or we have a new checklist, do staff actually know about it? The third level, it's even more valid but more resource intensive, is doing an audit. That is, our staff using this new checklist or procedure as intended. Typically, this means you have to observe people doing their work and auditing performance. And the last, and I think it's going to be the most valid, but the science of how to do it is still a little immature, we're still working on it, is to ask staff, do they believe that risks were actually reduced? You see, there's overwhelming data from cognitive psychology that your staff, or you if you're clinical, know what the hazards are, that your gut has a pretty good perception of reality. We just have to tap into it. And so we've been developing some surveys that after events will ask staff if they really believe risks were reduced. Now, we don't have it as part of this because the science isn't there yet. They're still trying to work out, who do we survey? Is it important that they knew about the event? Is it important that they knew about the interventions? And so there's more to follow on that. But even if just as a gut walking up to someone and saying, hey, do you think it really worked, could be informative. And finally, after you do these learnings, we want to make sure you share them both within your organization and amongst other organizations, because we've seen over and over again we're much more alike than we're different. And how do you summarize? Well, there's a couple really practical strategies. One is simply putting the answers to these 4 questions on one page. Being very succinct and ruthlessly simple for summarizing 4 questions on one page, great way to share. We also made a figure of those 4 questions that we'll share with you in a second that you can use. And again, have the courage to share not only within your organization, but within the collaborative if your institution approves. Now, as you know, when you're sharing with other organizations, there is absolutely no need for identified information, either at the patient, at the clinician level, or at the organizational level. The point is to see these systems, which ones were broken, what you did, and how you know it worked. As an industry, we don't do so well at organizational learning. It's amazing how many organizations, including my own, will have an event going on in one part of the organization. You may develop a really innovative solution, but there's no structure to share that with another part, so they struggle inventing their own things, perhaps suffering the same harm when we could have prevented it if we had some structure for learning. This is the one-page PowerPoint where we simply summarize the safety tip, put the case, what were the systems, what were the potential interventions, and then what did I actually do? So this is a fabulous case where a patient needed transvenous pacing. The doctor went to get the equipment, and as you may know, to do transvenous pacing, there's a cordis that is a sheath that goes into a catheter in the neck, and then there's a wire that goes within that you pace. And they both come in different sizes, and the operator, the clinician, has to grab the right combination. And predictably, as you would understand, they sometimes, or often perhaps, grab the wrong combination, and patients either suffer air embolism or risk of infections, or they bleed. So this happened one night. When I spoke to the nurse about it, the nurse kind of chuckled and said, "It's been happening for 20 years in my institution. This is nothing new. Every time we get new fellows or we have to do this, doesn't happen that often, the same thing happens again." So I stopped her and said, "Okay, time out, Sheila. We can't just do first order problem solving. We need to do second order problem solving. Why do you think this happened?" And she said, "Well, we don't have skilled or knowledgeable clinicians who know the right combination of equipment. But importantly, the environment didn't package the equipment rightly, and the medical device makers don't have a kit to do this." And so we said, "Okay, well, what's our most bang for the buck?" And we said, "Well, we could put an educational program, and we will, and we did. But because it's done so infrequently, why do we have to make docs guess what the right combination of equipment is? Why not package what they need together right now?" So Sheila said, "Okay, Peter, perfect. What I'm going to go do is I'm going to go in the supply room and tape the right size equipment together and write on there, this is the right side equipment. And then I'm going to form a team of all the people who use this equipment, and let's find out what they want in a centralized kit. We'll list that equipment, we'll send it to Central Supply, and we'll have them make up a kit that's a pacing kit, so it has all the equipment you need. Take 8 steps or multiple steps down to 1 and reduce the risk for harm." I looked at her and smiled, and I said, "Now you get it." This second order problem solving is the key so that Sheila doesn't say a year from now, "This has been happening 20 years and it always happens and it's just the way we work because all we do is recover and do first order problem solving." But now we have the skills and a mechanism to make sure that we do second order problem solving. Now I'll share with you, these aren't easy. We did do this. We formed a team. Sheila sent it down to Central Supply and unfortunately got pushback and saying kind of, "Who are you? Why are we going to do this?" And it took leadership and management now to follow through and said, no, yes, this is going to happen. This needs to happen. She has the authority. We need this to happen. And so you have to couple this with managers or leaders who have the authority to make these system changes or to commit the resources for it. But boy, when you start doing second order problem solving, it not only reduces patient harm, but it puts enormous joy back in patients' work because these constant failures that you have to recover from are draining and exhausting for our clinicians. Now, we're also taking this and applying it not just in CUFS, but in morbidity and mortality conferences and as part of our fellowship program. So our critical care fellows and residents have to investigate defects. Here's a list of some of the ones they did. I'm sure many of these happen in your organizations and what they did to fix it. These defects are happening all the time. What you need is a system to do second order problem solving. We've also taken this into morbidity and mortality conference, a great opportunity because you have all the clinicians there. Now, it requires some changing of your M&M conferences, and what I mean is that you can't review 30 cases, you can't go an inch deep and a mile wide. You have to pick 1 or 2 and really go deeply in them. You also have to invite everyone who touches the process, including your administrators, to be there because you now know that these are system problems, not personal problems. So it's not just the physicians there who often don't want to open it up because there's shame and darkness and guilty feelings when you're not perfect. We know we're not perfect. We're going to make mistakes, but we have to make sure we fix problems. And the system owners are often not the docs, but they're nurses and administrators. And then go through the 4 questions. They're great. They give you a structure to do it. Make sure you close the loop. In most M&M conferences, it's simply a brainstorming, divergent thinking where you don't close the loop. And then finally, share what you learn. What are some of the key lessons that we're asking you to focus on? Well, first, focus on systems, not people. You remember on the Science of Safety where we talked about that doctor who had the delayed transport of the patient from the emergency room. When we asked what he was going to do to fix the problem, he said, I'm going to push harder. You have a better bag of tricks now in your armamentarium to what are you going to do second order learning. And pushing harder may be a component of it, but it's really, really weak and not likely to be very effective. So do stronger systems. You have to make sure you prioritize and use these principles of safe design, of standardizing, of creating independent checks. I'd encourage you to go an inch wide and a mile deep. Really try to make system changes rather than checking a box. And don't forget pilot test. We're talking small tests of change. You don't have to redesign the thing. Start with one patient on one bed on one day, but try to make sure that you learn from one defect a quarter, that you could answer these 4 questions as your definitions of learning. So what's your action plan? Well, hopefully you will review the Learning from Defect tool that's available to you with your team and start to pick one defect on your unit that you think is a particular risk for you. I'd ask you to pick one that doesn't go too far outside of your unit. The more departments that are spanned, the more complex this gets to fix. So don't start with something that is a chronic problem that involves 8 departments and you're not likely to be very successful as you're getting going. You want to build momentum with this. And start by selecting one defect a month or a quarter and start learning from it. Consider using this structure in your morbidity and mortality conferences. It's a great way to add structure and really make improvements in safety to a meeting that's occurring anyways that often lacks some structured way to reduce or to do second order problem solving. And then once you reduce risk, post the stories, either the 4 questions or the figure, so that your staff could see who are your safety heroes, who are going beyond first order problem solving to really do that second order problem solving, and they should be rewarded for that. We post the stories of people who do this on our ICU or throughout our hospital as our safety heroes. We'd encourage you to do the same, and then finally share with others. Because as you remember, at the end of the day, we have to look Sorrel King in the eye and answer the question, are you safer? And we have a responsibility to do it. This approach is practical, it's proven, and it's just waiting your leadership to go try. This is Peter Pronovost working with you to improve patient safety, signing off.